Welcome everyone to part two of iAcademy's part one webinar series delivered by Dr. Felyx Wong. Thank you for joining us. We've got 28 participants, including the two of us at the moment. We'll just give it another couple of minutes to let people join. For those of you who don't know us, I'm Byron, one of the co-founders of iAcademy. It's a website and an online platform that we created to help other ophthalmologists prepare for the Duke Elder exam, ST1 application process, and FRCOphth exams from part one to part two oral. And Felix is a good friend of mine and is delivering the part one webinar series. He is currently an FY2 doctor on an academic year at Guy's and St Thomas's NHS Trust, and he won the Crombie Medal last year for scoring first across all sittings in 2024, which is incredibly impressive. So I also wanted to just quickly plug iAcademy's Part 1 question bank, which was launched last month. ماشي. Let's mute that person. And whoever's joined this webinar, you can use the discount code webinar10 to get 10% off our question bank. I'll put the details in the chat so you guys can have a look and explore what we have to offer. We hope it's a very useful resource for anyone preparing for the part one exam, which is, a very tough exam. Okay, so we've got over 30 now. Felix, do you want to start or should we give it a few more minutes? Up to you.
Yeah, I'm happy to start. 1 second. Can you see this?
Yes, we can. Thank you.
Cool. Hi everyone, thanks a lot for coming on a Sunday. Firstly, I'd like to apologize, I'm slightly ill. So teaching optics on a Sunday afternoon when you're a bit ill is probably not the best combination, but we'll try our best. I think the talk will be around 45 minutes. Unfortunately, like you're probably aware, optics is such a big topic. I simply cannot cover everything. There's just too much. And so I thought a nice, useful way to learn, perhaps on a Sunday afternoon, is that we just go through some questions together. And the structure essentially will be that questions, and then we go through some explanations, and then we'll go back to the question itself to discuss the answer options. These questions, essentially, the first few questions are just quite straightforward, but it does get a bit more complicated, and all of them are concepts that came up in my exam last year.
Honestly, very cheap.
Sorry, can you please
Sorry, yeah. Can everyone mute themselves, please, when you're joining?
Thank you. Cool. So the first warm-up question, I'm just going to give you guys like 30 seconds to have a think about it. So what is the dioptric lens power of a simple magnifying glass or a loupe that has a magnification of 2.5 times? So it's just something for you to have a think about, and then we'll go through the answers. Give it 10 seconds. Okay, so I'm gonna move on. What is a loupe? In case you didn't know, it's just a simple magnifying glass. You've probably seen it a lot in a lot of day-to-day clinical use. For example, people wear it on their glasses during surgery. It's just magnifying glasses. And the key takeaway from this question, the reason why I've included it is because this comes up every single year. This equation, they expect you to know this obviously off by heart. Essentially for a loupe, for a simple loupe, the magnifying power in this case is 2.5, given to us by the question, is equivalent to the dioptric power of the lens of the loupe divided by 4. So if we rearrange this equation, we've been given the magnifying power of 2.5, okay? And then if we times both sides by 4, 2.5 by 4, then we'll be able to work out the lens power, which is 10 diopters. So this is something that's really, really important to know. I know it's quite straightforward, but I just want to plug it in just so people are aware. And so going back to the question, what is the dioptric lens power of a simple magnifying glass? The answer is C, 10 diopters. The next question is, which of the following prisms causes a 180-degree deviation? Again, it's not the hardest question. It's relatively okay, but kind of a warm-up. I'm going to give you some 10 seconds to have a think about it. Is it Dove, Fresnel, Horror prism, and Wollaston prism? Okay, so before we move on to all of the prisms and stuff, I, again, don't have time to cover everything about prisms. There's all that stuff in the Elkington about angle of deviation and all of that stuff, which you should definitely look into. But just a quick refresher, because I'm aware that some people here are at different stages of their revision. You might know everything about Elkington, but similarly, you might have just started. A prism is essentially, I just think of it as a sort of like a triangular lens that bends the light. It's probably not very scientific, but you can just remember it that way. The key takeaway from this slide is that with a prism, you have an apex, which is the top angle here, and it also has a base. When you have an incoming light coming into the prism, essentially it gets refracted and then refracted again and leaves the prism. The main takeaway from this slide is, firstly, the prism bends the light towards the base. So as you can see here, the light is bent towards the base at the bottom. The other thing I want to mention is that if you as a person are looking through the prism, okay, so if you imagine this red dot is an object that gives off light, that enters the prism and then it gets refracted and then enters your eyes. What you will see as the image is slightly different. It's slightly shifted towards the apex compared to where the object actually is. So the other takeaway from this slide is that even though it bends the light towards the base, if you're looking through the prism, the image is shifted towards the apex. And that's really, really important for prisms, because essentially that's how they work, really. So what is a Fresnel prism? The top diagram here is a conventional prism, okay? A conventional prism is what you're probably all used to, what you probably think about when I mention our prism. It's like a sort of triangle which bends the light. But the problem is, if you want to put something like this, for example, behind the glasses, it's quite inconvenient. It's probably heavier and it takes up some space. So what some really smart people have done is they've converted this into something like this. Essentially, they have multiple small prisms with the same sort of angle, apical angle, lined into a single line like this. And essentially, this Fresnel prism will act similar to a conventional prism in the sense that they will have similar powers. However, the difference is that this is much thinner, and the other benefit is that it's probably lighter, so you can put it behind the glasses. So the benefit of a Fresnel prism is that you can put it behind the lens, it's lighter, weight reduction, and you can use it day to day for glasses. Some prisms that you should know for the exam. Again, this is something that came up in mine. First thing is Porro prism. It all gets a bit confusing because there's different names for each one, but there's 4 you need to know. One we've mentioned is Fresnel, but 3 here. So Porro. So what Porro prism does is that it's a very specific prism where it essentially sends, when you have light rays coming in, as you can see here, it gets refracted inside and it just sends the light waves back to where it came from. So this is what I mean by it's been rotated by 180 degrees. The other thing to be aware of for the Porro prism is that the image is inverted. So as you can see here, it's upside down. The F is upside down. So this is quite useful because you can use a pyroprism in instruments. And for example, if an image that's produced by, let's say, a telescope is upside down, you can put in some prisms to make it upright. I'm not sure if that's actually possible, but this is an example of how pyroprisms are used in real life. They're used to flip images. The second prism to be aware of is the Wollaston prism. I don't even know if I'm pronouncing it correctly, but what it does is it splits instant beam into two polarized emergent beams. So that sounds very confusing. What does that actually mean? So what is polarization? Essentially, if you look around your room, now it's quite dark, but the light rays, a lot of them are, if you imagine this straight line here is the axis in which the light is traveling, the light waves will all be vibrating along the axis, but they will be vibrating in different directions. So you can see the yellow ones are vibrating vertically here, and then you also have the blue ones that are vibrating horizontally. So a polarizer, how it works, essentially, the concept is that when the light goes through the polarizer, it turns all of the sort of it filters out the directions which are not what you want really. So as you can see here, before the polarizer, you have the blue and the yellow. The blue ones are the horizontal, the yellow are the vertical vibrations. But after it goes through the polarizer, it essentially filters out the blue ones, which are vibrating horizontally. So polarized light essentially is light that will vibrate in the same sort of direction. And this, again, has a lot of clinical implications, like some forms of microscopy, etc., which is why it's a very, very useful technology. So what Wollaston prism does is that you have light coming into the prism, and then it splits the light beam into two polarized emergent beams. And so that's very, very helpful. This is used in something called Javell-Schotz keratometer. I didn't mention anything here, but again, this is a very high yield information that you should be aware of. Javell-Schotz keratometer is a keratometer. So a keratometer is a tool that's used to measure the curvature of the cornea and the power of the cornea. And so within this specific keratometer, it uses this prism. And this is a common concept that they like to test you on in the exam. Vibrate in the same direction. So the last prism that I want to mention about is something called the Dove prism, or Dove prism, I don't know. Again, so it's similar to pyroprism in the sense that, as you can see here, the light rays that come in, they go through the prism and then they come out upside down. So it inverts the image, which is the same as the pyroprism. But the difference is that the pyroprism obviously sends it back to where it came from, whereas Dove prism just let it go through. So that's the Dove prism. So going back to the question, the correct answer is pyroprism, which is the prism that causes 180-degree deviation. So now the question is getting slightly more complicated. I'm going to give you 20 seconds to read through the question. So regarding the duochrome test, which statement is least likely to be correct? So just going to give you some time. Okay, so now we're going to move on. Before we touch on the sort of details, again, I'm sure many of you know this already, but just a quick refresher, a reminder in case you didn't. In patients who are myopic, so who are short-sighted, their eyes essentially are too good at converging the light. That's the way I think about it. So usually you have light rays coming into your eye, hits your cornea, and then they get refracted, and then they get focused. So the focal point usually is on the retina in a normal eye. But in patients who are myopic, your eyes are too good at focusing the light rays. And so the focal point is in front of the retina. In patients who are hyperopic, in other words, they're long-sighted, your eyes are essentially too weak in the sense that they can't converge light as well as they should be. And so when the light rays hit the cornea, the focal point ends up being behind the retina. The other concept before we move on that we should be aware of is something called chromatic aberration. So if you imagine white light, which contains all of the different colors, red, green, blue, what chromatic aberration, essentially the key takeaway about what this means is that the light waves with shorter wavelengths, in this case, the blue and the green, they get refracted more. So as you can see here, they're focusing more and closer to the lens compared to the red. So the red waves are longer in terms of their wavelength, and that's why they get refracted less. So that's the rule of chromatic aberration. Shorter wavelengths are refracted more compared to longer wavelengths. So the duochrome test, the reason why I've included it in this sort of MCQ practice session is because it's, again, a concept that they always like to test you on. It's based on the principle of chromatic aberration. As you can see here, I've got an eyeball and then I've got light coming in, and then you have chromatic aberration where red light, like I said, has longer wavelength, so it gets refracted and the focal refracted less, and the focal point is behind the eye. And then the green light is, which has shorter wavelength, is refracted and focuses in front of the retina. That's what I said earlier. The key thing to know is that, so the diagram we have here is a normal eye. Like I said earlier, you have the red light behind the eye and the green light in front of the eye. So in a normal person, if you ask them, if you've been to the opticians, if you wear glasses, you'll know that people will ask you, oh, which side looks clearer? Is it the red or the green? As you can see here, neither the red or the green are on the retina itself. And so they are, you can think of it as they're equally blurry, but they look the same, essentially. So in a normal person, this is what they will say, the red and green look the same. In patients who are myopic, like I mentioned earlier, the eye is too good at focusing the light rays. And so naturally, all of the light rays will be, all of the focal points will be pushed more forwards compared to a normal eye. And so what you can see here is that because the eye converges the light rays more than usual, the red light, which is previously behind the eye, is now sitting on the retina, and the green light is now further in front. The green focal point is further in front. And this is why people who have myopia will say that the red side looks clearer than the green. So like what I've written here, because in myopia your eyes converge light rays more than normal, they're better at converging the light rays, the red looks better than the green. So the take-home message here is red is clearer than green in patients who are myopic. Similarly, like I mentioned earlier, if you imagine in a normal eye, again, the green focal point will be in front, the red focal point will be behind. In patients who are who have hyperopia, in other words, they're long-sighted, the eye is not as good at converging the light rays compared to a normal eye. And so when this happens, your green focal point, which used to be here, if you can see my red dot, it is now pushed further back because you have hyperopia. And so in these patients, they will see green better than red. That's what they will see too. That's what they will say. So the take-home message from this slide is that in hyperopia, green is clearer than red. So the next thing that I want to talk about is, well, now we know if the patient is hyperopic, if the patient has hyperopia or myopia, what if we start and try correcting it, right? So if we put a lens in front of so this patient has hyperopia, so the focal point is pushed further back because the eye is not that good at converging. So if we put a convex lens, which is a plus lens, that brings the focal point forwards, what will happen to the focal point? So you see, this is what happens. It'll bring the focal point forward again. And so now they will say, oh, it looks the same again. So that's how that's what happens. But then what's really important to also be aware of is what happens if we overdo it, right? If we put a really, really strong convex lens, what will happen to the red and the green focal points? Well, now you've kind of overdone it. This patient had hyperopia in which the focal points were too far back, but now you've put a really, really strong convex lens and you've pulled the focal points really forward. So now the patients will say that the red looks better than the green because you've pulled the focal points really, really forward. So this, when you see, for example, if questions say over plus, that's what this means. You put a plus lens that's too strong. In other words, you've pulled their focal point too far forward. And similarly, if I'm using like the same idea for over minus, so if this is a patient who has myopia, like I said earlier, myopia is if your focal point is in front of the retina, and if you're trying to correct it using a diverging lens, so a minus lens, what will happen is that you essentially push the focal point too far back, and the green focal point will now be sitting on the retina. And so they will say that the green looks better than the red. So that's the sign that you've overcorrected a myopia. In other words, I've seen some textbooks say over minus. I've just left it here so you know what it means if that comes up in questions. Another thing to be aware of is that if you do over correct someone's myopia, in other words, if you've used this diverging lens and really pushed back the focal point, then what the patient will do is they will start accommodating. Accommodation, as you are all aware, is when the ciliary muscles contract, which causes your lens to become rounder and then become more convex. And so this will then bring the focal points back forwards. So if I use a pen, so like I said earlier, the diverging lens, if you overcorrect a myopia, you'll move the focal point too far back, but then the eyes will try and compensate by accommodating, and by doing so, it will bring the focal point back forwards onto the retina. The problem for this is that it will obviously lead to a lot of eye straining if it's long-standing. Sorry, if you haven't muted your mics, please could you just mute your mics so that I can, I'm not distracted. Thank you. The next slide, so this slide is about color blindness. So a lot of people often fall into the mistake doing these questions for the FRCOphth, thinking that if you're colorblind, then you can't do the duochrome test. But the thing is, the color blindness does not invalidate the test. The reason is because if you think about it, even if you don't know that the left side is red and that the right side is green, chromatic aberration still happens. So you can still tell if left side is clearer than the right, or if right side is clearer than the left, or if they look the same. So duochrome test can still be done in someone who's colorblind, even if they don't know which side is red and which side is green, because chromatic aberration still happens. I hope that makes sense. So going back to our question, regarding the duochrome test, which statement is least likely to be correct? So myopic patients see black letters on red background more clearly than black letters on green background. So this statement is true. As you can remember, in people with myopia, the focal point is too far forward. And so because the focal point is too far forward, the red light will be sitting on the retina, whereas the green focal point will be sitting further forward. And so they will say that the red side looks better than the green. Similarly, in the duochrome test, like I said earlier, you can use it to also tell you if you're overcorrecting, because when you've gone overboard with the correction, the patients will start saying the opposite, which is what I mentioned earlier. In a patient who's overcorrected, myopic patient who's maybe using accommodation for distance vision leading to eye strain, again, like I said earlier, this is true. So like I said earlier, myopia, the focal point is too far forward. And so the correction is using a diverging lens to push the focal point posteriorly so that the focal point lands on the retina. But if you overdo it such that the focal point is now behind the retina, then the eyes will start to accommodate to bring the focal point back forwards. And if this persists, then it strains the eyes. The last point, the last statement, color blindness invalidates the duochrome test. So this statement is, so this is the correct answer because this is the false statement. I know it's a bit confusing. Which statement is least likely to be correct? So this is the correct answer. So color blindness invalidates the duochrome test. This is incorrect. You can still do the duochrome test if you're colorblind. This question, it's a bit long, so I'm gonna give you like 20 seconds again to read through. Okay, we're going to move on. So the key takeaway message from this question is the SRK formula. Even though it's not, this formula is not, there's more up-to-date formula that are used nowadays, but the exam still expects you to memorize this off by heart. What is the SRK formula in case you haven't come across this yet? So when you're doing cataract surgery and you have to calculate the power of the intraocular lens that's put into the capsular bag, you can use different equations to help you estimate what's the ideal power for the patient's intraocular lens. And SRK formula is one of the sort of, I think, original formulae, but now there's more newer formulae that you should also be aware of, which I will touch on later. So the formula is P equals A minus 2.5 L minus 0.9 K. I know there's not much sort of explanation here. You just need to understand this. You just need to memorize this formula. So P is the IOL power, and this is the number that you want. This is the power of the intraocular lens that you are putting into the patient's eyes. And the units is diopters. A is a constant, and this constant is affected by many, many different factors, including the make of the IOL, the haptics, also things like even the surgeon, I think, like who does it, it affects the constant as well. L is the axial length. So I've got a diagram here. What I mean by axial length is like the length of the eye from the front of the cornea to the back. And this can be measured using ultrasound scan. And for the purpose of the formula, has to be in millimeters. K is the corneal refractive power. So you can use keratometry to measure the curvature of the cornea and the power of the cornea. And that value is then put into this formula to give you the overall E, which is the IOL power. Going back to the question, I've just got the question stem at the top. So this is the formula that we just mentioned about. Okay, these questions come up all the time, which is also why I've included this. The correct formula that the surgeon should have put in is P equals A. We can ignore this constant because it's the same. A minus 2.5 L. So L is the axial length, in which case it's supposed to be 23.8. Minus 0.9 times the K value, in which case it's supposed to be 44.5. But what the surgeon has actually done instead is P equals A minus 2.5, blah, 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 minus 0.9 times 43.5. So this is a mistake by the surgeon. And so because this number is now lower than what it's supposed to be, then therefore this number is bigger because the constant is taking away a smaller number. And so
update FD.
Sorry? Hi, sorry, if you don't mind just muting your mics. Thank you. Yeah, cheers. Going back, so because this number is now smaller than what's supposed to be, the overall p-value here is higher. In other words, the actual power of the intraocular lens that the surgeon has calculated is an overestimation of what it's supposed to be. In other words, it is stronger than what the patient actually needs. I hope that makes sense, and I hope I'm not going too fast. And to show this sort of through a diagram is that if we imagine this is the IOL, the green is the IOL. If the IOL is too strong, it means that it will be converging the light in front of the retina. So instead of focusing the light on the retina, the focal point has now been shifted forwards. So again, relating to one of the options mentioned in the question, because the focal point has been shifted forwards, you now need a minus lens, which is a diverging lens, to further push the focal point back to the retina. So if that IOL was inserted into the patient's eyes, if that was put into the patient's eyes, then the patient will need to wear glasses to essentially correct for that mistake. So going back to our question, just looking at option B, the implant used is too strong for this eye. That is true because the focal point is now in front rather than on the retina. So it has too strong of a converging power. Statement C, the patient will require minor spectacle correction for optimal distance correction. That is true because the focal point is now in front of the retina, so you need a minus lens or a diverging lens or a concave lens. There's so many different words for the same thing to push the focal point back onto the retina. This is a slide that just shows you what they mean by ciliary sulcus lens. So for people who are, for example, if you're in foundation training and thinking of sitting the ophthalmology exam, I don't know what this was. Essentially, obviously with intraocular lens, it's usually put in the capsular bag, which is what you can see here, the yellow line here. But in certain situations, you would also put the IOL in other locations, and one of the locations is the ciliary sulcus, which is slightly more anterior, as you can see here. So as you can see here, if the lens was placed in the ciliary sulcus, which is more anterior, then the lens itself was already too powerful. The focal point was already in front of the retina. So if we move the IOL even further forward, then it will make the situation worse. It will make the focal point even more further forward. So going back to the question, which of the statement is false? Implanting the lens in the ciliary sulcus rather than the bag would have improved the refractive outcome. So this statement is false because implanting the lens in the ciliary sulcus would actually make the situation worse rather than improve. The final option, option D, alternatives to the SRK formula are used depending on axial length. So this is something just to be aware of. So essentially SRK, oh sorry, that's a typo, I think. SRK formula is like the first formula that's used, but then there's a newer formula that was released like SRK2, then SRK/T. There's also other ones, including Hoffer-Q and Holliday formula. The main reason why I've included this slide is because this is a concept that they like to test you on as well. Essentially, for patients with smaller eyes, in other words, with a shorter axial length, sometimes the Hoffer-Q formula is preferred over the other ones. But for the purpose of the exam, you only need to know the SRK formula. You don't need to memorize the other ones. So going back to the question, statement A is the correct answer. The other statements, so which of the following statement is false? So statement A is false. The other ones are all correct. True, true, and true. Yeah. I'll give you some time to sort of have a think, but yeah. Now, moving on to the next question. Which statement regarding contact lens correction is false? Corneal warpage regresses after contact lenses is removed. Truncation of lenses provides greater stability. In myopes, contact lenses reduce the need for convergence compared to spectacles. Rigid contact lenses are used for keratoconus to ensure uniform surface for light to focus more effectively. Again, I'm going to give you 20 seconds. Okay. Going to move on. So a quick recap of how prisms work. Like I mentioned earlier. So a prism, essentially, you can think of it as it bends the light towards the base, right? But importantly, it shifts the image. So this is the image here. It shifts the image towards the apex, and that's the apex, right? So that's the key thing to remember from this slide. With plus and minus lenses, you can generally think of them as sort of prisms as well. So with a convex lens, you can think of it as two prisms placed like this, with their bases facing towards each other. And similarly, with a concave lens, you can think of it as two prisms placed like this, with their apices facing towards each other. And so this is a sort of bird's eye view of, imagine if you're looking down at someone and this is the right eye, this is the left eye, okay? And they're looking forwards at an object, and you have, so this is in this case, this is a myopic patient, and they're wearing concave lenses. Like I said earlier, if you remember, myopia is when the focal point is in front of the retina, and so you're wearing concave lenses to push the focal point back onto the retina. So what happens when you look, when the eyes converge? Okay, so when the eyes look at the object whilst wearing these glasses, okay, like I said earlier, in a with a prism, the image is shifted, the image that's produced from the prism is shifted towards the apex. So the apex is here, yeah? So if you have an object that's in the middle and you try to look at the object by turning your eyes inwards, the image that you actually see has been shifted towards the apex because of this prismatic effect. What this actually means is that because when you're turning inwards, your glasses are acting as prisms, and that it's shifting the image outwards towards your ears, it means that your eyes don't need to converge as much because the image has been shifted laterally or temporally, if you want to talk. Yeah. And so that's why the take-home message from this slide is that with a minus lens, in other words, a concave lens, your eyes converge less. Now, if we flip this the other way around, okay, if we're trying to look in, if we're trying to look at an object and through a convex lens, so this is a patient who's hyperopic, hyperopia. In other words, they are long-sighted, so the focal point is behind the retina, and the purpose of the convex lens is to bring the focal point forwards onto the retina, okay? So similarly, like I said, you can think of the convex lenses, you can visualize it like this, right? So the object that's shooting the light rays towards the prism will produce an image that's more nasal because the image has been shifted towards the apex of the lens, which is here. And so the take-home message for this is that for people with hyperopia that wear a plus lens, the eyes have to converge more. Okay, key thing is more, because the image has been shifted more towards the middle. So they have to turn their eyes more to look at the image. Going back to the concave lens in the myope, okay, I just want to highlight this. So this all happens because you are turning your eyes inwards whilst your glasses are staying stationary. So they're not moving much, right? Because they're just sitting there on your nose. And that's why you have this sort of effect where the image is shifted out or shifted in. So what happens in contact lenses? So in contact lenses, you have the actual glasses, so the lenses are stuck on your cornea, right? So now when you try to turn inwards, because they're stuck on your cornea, the lenses turn inwards with you, okay? So your eyes are turning inwards with the contact lenses. And so you lose that prismatic effect where the image is shifted towards the apex because you're constantly looking towards the center through the lens. And so in patients for example, if you have myopia and you normally wear a concave, so minus glasses, and if you're switching from a concave lens if you're switching from a minus lens to a minus contact lens, it means that you have to converge more because usually the minus lens would help push. So if we go back to the previous diagram, usually the minus lens would help push the image outwards, right? But now you lose that effect because you're just looking straight through. And so with a minus lens, you have to converge more compared to someone who wears glasses. And it's the opposite for if you are going from a plus lens, so plus glasses, to a plus contact lenses. Because usually if you're wearing, if we go back here, so if you're wearing glasses, if you have hyperopia, and if you're wearing a convex glasses, right, the image is shifted towards the middle, and so you usually have to turn your eyes inwards more when you're wearing glasses because of the effect caused by the lens. But if you're now wearing contact lenses, that effect is removed. So when you're wearing contact lenses, you are converging less compared to when you are wearing glasses. I hope that makes sense. If it doesn't, this is all recorded. You can just listen to it again. Hopefully that will help. So going back to the statement, which statement regarding contact lens correction is false? Okay. We haven't gone through the other options yet, but option C, in myopes, contact lens reduces the need for convergence compared to spectacles. Okay, so this is the correct answer because this is the false statement. I've given you a lot of true or false sort of questions. So like I said earlier, because in patients who have myopia, usually when they're wearing glasses, the glasses would push the image more temporally, which means that they don't have to turn their eyes inwards as much. But because you're wearing contact lenses, you now lose that effect, and so you have to actually converge more compared to compared to glasses. So this is false because it increases, contact lenses increases the need for convergence compared to spectacles. So now going through the other options, corneal warpage. So we're reaching sort of the, I know it's been quite a quick talk actually, but yeah, we're reaching towards the final few slides. Essentially, what is corneal warpage? Warpage is essentially when you wear contact lenses for a long time, it can affect the shape of the cornea. And if you're someone who's previously had laser eye surgery before, like me, you'll realize that when they ask you to go to have assessment in the eye, for the cornea, they'll ask you to stop wearing contact lenses for, let's say, like 2-3 weeks before the assessment. And it's essentially to allow the shape of the cornea to return back to what it is like without contact lenses. Okay. And just something to be aware of is that sometimes, because of this phenomenon of corneal warpage, when you've been wearing contact lenses for a long time, which changes the shape of the cornea, the glasses that you usually wear that previously worked may no longer correct your vision adequately because of this problem with the curvature of your cornea. But this is something that is temporary and will resolve over time. What is truncation? So contact lenses can actually, this is something that's mentioned in the Elkington book, but contact lenses can be truncated, it can be cut. In certain situations, you want to make contact lenses more stable. For example, if they're bifocal, you want to stop contact lenses moving around. You want to stop them from rotating in the eye as the eyes blink. So what you can do is you can cut a bit off essentially, and this bit will essentially sit on the, I think, the lower eyelid. It will essentially stabilize it and make it rotate less. So that's why truncation is done. The last slide is about keratoconus. Okay, so again, I'm sure most of you know what keratoconus is, but I've just included it here for people who may not know. A normal eye is obviously dome-shaped like this, but in patients with keratoconus, they will bulge out, which like a cone shape essentially. And with these patients, often you need to use a rigid contact lens rather than a soft contact lens. The reason, if you can probably imagine the reason. So if you're using a soft contact lens, it will essentially just wrap around the problem. So what you actually need is you need to provide like a new surface for the eye to refract the light and focus the light beam. And you want that new surface to stay in shape rather than something that's flexible and can get molded around. If you put patients with keratoconus with a soft lens, it will sometimes just wrap around the problem, and this is not helpful if you're trying to correct the vision. You want something that's solid and stays the same, basically. So going back to our question, which statement regarding contact lens correction is false? Corneal warpage regresses after contact lenses is removed. That is true. Truncation provides stability. That is also true. And rigid contact lenses are used to ensure uniform surface for light to focus more effectively, allowing for clearer vision. That's also true. That's the end of the session. I know it's been quite quick. I do apologize. I'm feeling a bit ill. So if there's any questions, if there's anything that's not clear, please let me know. I try to keep it short and snappy because I know it's a Sunday as well, and I don't want optic sessions to be too long and you can't absorb everything that's been taught. So hopefully that was helpful. Yeah, thank you. Does anyone have any questions?
Thanks, Felix, for that talk. A question from Mitchell Titley. Are you allowed to use a calculator in the exam?
No, I don't, not for me. I didn't, yeah.
Okay. Next question is, well, how to prepare for biochem, microbiology, and other non-ocular topics? Perhaps that could be a topic of a future session. What do you think?
So biochem, with biochem, these are all topics that I just basically learned everything from doing question banks, really. I didn't really have any specific resources. A good way of something else that I did was I just used ChatGPT. with biochem and microbiology, a lot of the times it's really helpful to learn through comparison. And so what you can do is you can get ChatGPT to compare, to produce comparison tables. So for example, you sometimes get questions on, let's say, comparing the contents between aqueous fluid and blood plasma, right? So for example, aqueous fluid has more of this, more of calcium than blood plasma, or it might have less potassium. I'm just chatting rubbish. I don't know if that's true. What you can do is you can get ChatGPT to create these comparison tables, and then you can just do cover up essentially to help you remember them. But otherwise, I've learned most of them. I didn't use any specific books or any specific resources. I just used question banks really to learn from doing the questions. The MCQ usually is 4 options. Yeah. What's the difference in diopters between red and green? I don't really understand the question. Sorry. Yeah.
Dan, if you're still here, are you able to qualify your question a bit more?
Yeah. Which question banks would you recommend? I would recommend the iAcademy question bank because I have had it actually looks amazing. So definitely give it a look, check it out. I've tried using the questions as well. The questions are really good. Explanations are also really good. The other ones that I've had a look at, people have said good things, are iDocs is also really good. Don't get what's the other one? Sorry, the past medicine one for FRCOphth. Don't get that one. It's a waste of money.
Okay.
No worries. Yeah, I hope you found the session useful. Anyone else got any questions? Hope that was clear. Difference is 0.25 between yellow towards green and red. Ah, okay, thank you. I did not know that. Yeah. In duochrome tests, red and green light is typically around. Fine, yeah, I did not know that, so you got it from Google. Yeah.
Okay, should we leave it there then?
Yep.
Thanks so much, Felix.
No worries.
If anyone, so this is the idea is it's going to be a webinar series. If anyone has any suggestions on future topics for Felix to deliver, please email us at team@i.academy or message in the WhatsApp group, the part 1 or you can find us via chat on the website. Thanks very much, everyone. Have a
Thank
good
you.
rest of the weekend.
See ya. Have a nice Sunday.
Thanks,
Bye.
Felix.
Bye.